Ladies and gentlemen, welcome to Atrium Health Innovates, the first in a series of virtual community hall meetings hosted by Atrium Health Foundation. I'm Armando Chartier, the president of the Atrium Health Foundation, and I'm delighted to be able to launch the first in a series to engage community leaders and highlight areas of leadership and innovation within Atrium Health. We're glad to have you joining us via Skype and to have some of you here with us at the audience for today's meeting, featuring innovations in behavioral health. Please note that if you have questions that arise during the presentation, you may submit them for the question session to townhall@atriumhealth.org. That is townhall@atriumhealth.org. Please join me in welcoming our program facilitator, Lou Solomon, local author, TEDx speaker, and the founder and CEO of Interact, a communications consultancy. Lou and her team have worked with Fortune 500 organizations such as Wells Fargo, Duke Energy, and Bank of America. She's also an adjunct faculty member at the McColl School of Business at Queen's University in Charlotte, North Carolina.
Well, thank you so much. I am here with my dear friend, Martha Whitecotton, who is also the Senior Vice President of Behavioral Health at Atrium.
Thanks, Lou. I think we met the first time when I visited Interact Studios and did the Authentic Speaker Series.
Yes.
So I would say if this is good today, you have Lou to thank for that.
Well, she's going to make me look good, I know that. The subject of years, I think that's been 12 years ago at least, maybe 15. So. And when you think about that being amazing, what about a career that spans 30 years? You've been with Atrium 30 years, that if I'm not mistaken began in 1988. You were a nurse, you started as a nurse, and then eventually wound up as the president at the Levine Children's Hospital, which is when I met you, or at least you were at Levine when I met you. And then in 2013, you took a rather extraordinary leap of faith to behavioral health. Tell us what drove that. What was behind that pull for you?
I've been asked that question a lot. I think, when you work for a healthcare system that is as growing and innovative as Atrium Health is, you have a lot of opportunity. And when I had the opportunity to lead the Children's Hospital, we knew we had this strong foundation of services, but we knew we could take it to the next level. And in partnership with our community and philanthropy, the Children's Hospital was built, and we were able to build world-class services and bring world-class services to the Children's Hospital. And when I was presented with the opportunity in behavioral health, I saw it as exactly the same thing. This strong foundation of services that were present in our community, but the opportunity to change it and transform it and really bring another level of care to this community. So that's really what interested me. I think I like a challenge.
Yeah, and you've been busy, because I have to brag on Martha a little bit. She did not tell me this, I had to dig on it, but just last year you received the Visionary Leader Award from the National Council of Behavioral Health, which is a very big deal. And the 2 years prior to that, there were 2 other awards from the council that came to the facility in regard to, I think, innovation and technology and whole person care. So it has been a good leap.
Yeah, and I think our team would agree it's been a busy 5.5 years. We've all been busy and working hard. But when I came to behavioral health in a dyad leadership team with a psychiatrist, we were given a challenge, and that challenge was really to transform the care delivery model and really be innovative and think about how we redesign services to make them scalable across a large geography, because our system covers rural markets and urban markets and states. And how do we then make them sustainable financially? Because if we need to grow these services, part of the challenges in behavioral health are that sometimes the revenue doesn't pay for the services that you need to deliver. So we had to think how to be cost effective and how to be clinically effective in program design. And so we really sort of skated towards that all 5 years. How do we move towards that mission?
Yeah. Martha, on a personal level, mental illness struggles touch our friends, our colleagues, certainly have touched my family. And still yet, even though there has been progress, I know that stigma that still has a way of coming with the struggle. Tell us a little bit about that.
I looked up the word stigma in the dictionary just out of interest because we talk about it all the time, and I thought, how does Webster define it? And it's defined as a mark of disgrace. And it's often associated with discrimination or discriminatory behavior. And a person told a story one time about stigma that I thought was a great illustration, so I'll share that with you all. He said that people are afraid of things that they perceive as incurable. And years ago, many of you will remember, if you're my age, that was cancer. People didn't tell people they had cancer. They were ashamed, they were scared that people would think it was contagious or you could catch it. And then it was HIV/AIDS, and now it's mental illness. And they perceive it as incurable, but the great news is that 80% of people with mental illness or substance use disorder can be in remission. Remission is recovery, and only 20% are. And the reason that the 20%, the reason there's that huge difference is really about access to care. Not just access to care, but access to care that is clinically effective and cost effective for that patient. And so that has driven us.
Yeah, absolutely. Well, tell me how Atrium is changing the traditional model.
That's what we've been about every day. Atrium Health has a rich history of telehealth and telemedicine. We've been delivering virtual care services on that platform for many, many years. And in mental health, interestingly enough, very strong services in telepsychiatry. And we also operate a call center that does about 200,000 calls a year, which is telehealth. That's what it is. And so we decided to build on that platform. And we decided we had to take care of crisis. We have crisis every day. We deal with that every day. But we wanted to really get upstream. You know, think about if the earlier we can catch someone, the earlier we can diagnose, the earlier we can find illness and begin effective treatment, we can change trajectory of illness. We can change that patient's experience with their illness. We can change how they manage life. You know, we can perhaps move them to recovery more quickly. And so we've been about designing programs that are upstream. And that speaks first, probably primarily to our integration to primary care. And so that also has a stigma overlay, Lou, because primary care is a place people feel very safe. It's estimated that 50% of people who receive a referral to a psychiatrist or a mental health professional never keep it. I think there's a combination of problems there. Cost, access, availability, stigma is a big reason. People are afraid of their car to be seen in the psychiatrist's parking lot. But they trust their primary care provider, so much so that 45% of people who complete suicide saw their primary care provider within the last 30 days. So that is where they're seeking help. So we thought if we can meet them there, then we can get early intervention, screening, and work to build the competency and the confidence of our primary care providers to start treatment and to begin treatment and manage treatment for mild to moderate mental illness. And we are doing that with a virtual team at their back. So we have a psychiatrist, a psychopharmacist, a team of mental health professionals, licensed professional counselors, licensed clinical social workers, and health coaches who then help carry that patient into their treatment and through their treatment and back them until they're in remission, working in partnership with the primary care provider. And that's been probably one of the most exciting things that we've done, a very exciting add-on to the services that we were already delivering that really spoke to that upstream.
How, Martha, is the model you describe, what differentiates that, just for our context, from other models?
There's long historically been mental health services delivered in primary care, typically delivered with a professional that's embedded in the practice. The challenges we saw with that model were, number one, sustainability and scalability, just because of the size of our healthcare system, the geography of our healthcare system, the sheer number of people that would take to make happen. It also is limited then to the person that's in that practice. So say that's a licensed clinical social worker. They still don't have access to a psychiatrist or a psychopharmacist or the whole scope of treatment. And so we felt like if we could do this on a virtual care platform, we could really strengthen the model and give the patient everything they need through that platform And it's been very successful. In fact, we looked at the outcomes. There's 80 randomized controlled trials that are published that are based on embedded models. So we looked at their outcomes, and we knew it was our job to replicate those outcomes. And we've actually done that and a little bit better. So we've achieved the same rates of remission from depression, the same response to treatment, the same decrease in suicidal ideation, the same physical health responses to treatment that we've seen published. And so we're excited that it's working.
Yeah. Can you give us a high-level snapshot of all the behavioral services, health services in our region?
Yeah, it's pretty vast. I think people would be surprised to know. I'll start with our Behavioral Health Charlotte campus, and that's really where care is centralized for the patients who are the most seriously mentally ill. They have not only inpatient beds, obviously, and that's our only campus that has child and adolescent beds. So they have inpatient services. They have really the only psychiatric emergency department in the state. Really in the Southeast, that's just a dedicated standalone psychiatric emergency department, staffed by psychiatrists. They also have on that campus a series of outpatient programs, and those are scaled according to the degree of illness of the patient, if you will. So we have an outpatient medication clinic, which is a typical see a psychiatrist or an advanced care practitioner in a practice, to manage your mental illness through medical treatment. But we also have a clinic, and we call it our Adult Integrated Continuum because it's an integration of their care that supports the most seriously mentally ill in our community and gives them access to the treatments that they need. And then we, to extend that one step further, have a assertive community treatment team that actually helps manage patients that are in the community, living in the community, and tries to help them manage their illness and live successfully in the community. So it's a whole series of services. We also have two partial hospitalization programs, which are step-down services for once you leave the hospital or perhaps on the front end before you come into the hospital that are day treatment. We have one for child and adolescents and one for adults. So that campus has an intense array of services, really structured much like a community mental health system. And those were the services that we transitioned from Mecklenburg County back in 2012. And then we have the system at the same time that they made this leap into behavioral health, built a brand new hospital in Davidson. And the team was able to design that hospital and think about the environment of care. And this really resonates with me because we did the same thing at the Children's Hospital. We spent as much time worrying about the medical treatment the patient would receive as we did worrying about the environment of the care that they were going to be in while they were receiving it. Because your environment affects your ability to heal. Access to natural light and being able to go outdoors. Those things are powerful when you're healing. And that is the way we were able to design the Davidson campus, from ground up, where patients have all kinds of access to outdoor access, outdoor activities, a gymnasium, a cafeteria, lots of natural light, private rooms, things that are really conducive to healing. And then we manage several inpatient units in hospitals across our system where it keeps treatment local in the community and allows those community hospitals to still run those services. We have the integration program into primary care that I talked about. We do telepsychiatry for 22 emergency departments. I think over 12,000 telepsychiatry interventions last year. And we provide employer-assisted assistance programs to employers all over North and South Carolina, and also to Atrium Health for their employees. I'm sure I'm leaving something out, but I already spoke about the call center. So pretty large array of services that we are able to provide. I think people would be surprised to see the investment Atrium Health has made.
Yes. Okay, we know that mental health issues do not discriminate, and they cross all demographics and affect people from all walks. What is being done to make certain that folks in all walks receive the health care they need?
I think that the services that I was describing, number one, I would talk about the services on the Behavioral Health Charlotte campus because those patients are the most disadvantaged by their illness. There was a study published in the journal in JAMA about the number of disability life years associated with chronic illness. And mental illness has the highest number of disability life years. Because people with serious mental illness are often diagnosed in their late teens, early 20s, and then they live the rest of their life with this illness and managing this illness. And so the services there are often, they're targeted at helping people live their life with this illness. And one program I'll talk about that we did in partnership with our managed care organization, Cardinal Innovations, and with the state of North Carolina was our First Break Psychosis program. And that's really about grabbing those young people at their first diagnosis and helping them learn to live with that illness. What most people's experience of that is their child becomes ill, they are in the hospital, and then they're discharged from the hospital, and they just go home, and then they don't know what to do because there are no services. There's none of these transitional services. So the First Break program really provides that transitional support to help a young person now grasp a different life that they're going to live and how they're going to have to take care of themselves in order to be successful in life. And I'm going to understate their success, but I know of at least 3 young men that have returned to college, 1 to law school because of the First Break program. And that changes your life. It changes your life. So that's a huge investment. I think our virtual integration into primary care, payers don't currently acknowledge that, but Atrium Health's determined to make that investment to change the way patients have access to treatment and hopefully drive their overall health. And in our vision, ultimately drive down the overall cost of care. Because if you think about your motivation to take care of yourself, to diet, to exercise, I mean, everybody in this room and on the webinar probably struggled with that at one point. Well, imagine pairing that with a mental illness. And so your motivation is even less because you're struggling first with this primary mental illness. All of this physical health comes secondary. So it's estimated that having a mental illness with a chronic illness drives the cost of care up 200 to 300%. So imagine if we can get people successfully into recovery, they can begin to take care of their physical health. And they can begin to get better, get up off the couch, take a walk, pay attention to what they're eating. But first, we have to address that primary problem. And so I think driving care upstream helps with that. Wrapping our arms around the most ill helps with that. And those are all improving access to care.
Yes. Now, certainly a good bit of Atrium's service area is rural. So what is being done to deal with that challenge?
I think we are relying primarily on our success with virtual care. Because these are communities that you cannot entice a psychiatrist to. Psychiatrists, there's very few psychiatrists in this country, only about 40,000. I think 50 to 55% of them are over the age of 60. So it's pretty scary thinking about the future of access to care. And in many, I think it's estimated that in 50% of the counties in the United States, there is not a single practicing mental health professional. So how are we going to get a mental health professional into that community? And our fastest and best way to do it, now that we know it works, is to use that virtual care platform. And we've seen both in telepsychiatry in our emergency rooms and with our primary care integration program, patients are not at all opposed to that model. And we've made it very simple on the technology so that it's not complex. We don't have to worry about devices. Your telephone is a very successful instrument in telemedicine. And we have maximized that. And if they do need to be on a screen, outfitting their doctor's office with that screen, so so that they could go to the doctor's office and use the telemonitor. But our patients are receptive to it, even our very young patients, and it's the most effective way for us to drive care. Now, we're interestingly enough working on a potential plan with a group of hospitals in Western North Carolina. A couple of years ago, the state earmarked some funds to build additional inpatient psychiatric beds, but they made a contingent that you can only use the funds in a rural market. So that's great, it's additional beds, but if they can't recruit psychiatrists, then how are they going to keep those beds open? So they came to us and said, we've seen that you've built this great, large group of psychiatrists. It's an exciting group, it's an innovative group, and we think you'll be able to recruit. So could you help us build a staffing group for Western North Carolina? And perhaps they could work there a couple years and then come to Charlotte or come to one of our other systems. But they see this opportunity to grow their career and start out in West. So we're working on a proposal, so fingers crossed that'll work. But that's another exciting way to address those challenges in rural health.
Yes, yes. We've touched on this a little bit, but I'd love for you to speak again to this idea of the intentional management of an experience when so many people are already in crisis when they come to you? What's being done to improve that experience?
Two examples come to mind immediately, and I'll talk first about our work in the emergency room. North Carolina has twice the rate of patients presenting to acute care emergency rooms with a primary mental illness, a primary diagnosis of mental illness, as the rest of the country. So North Carolina particularly is in crisis. We are underbedded. We don't have access to care in the community, so patients are seeking the only place they know to go, which is an emergency room. When I first came over into behavioral health, our average length of stay for a patient in an emergency room with a mental illness was 45 hours. Imagine sitting in an emergency room for 45 hours, and that was the median. That means people were there longer. And we knew that we had to begin to chip away at that length of stay, and then to think about how to help those emergency departments care for those patients while they were in their emergency departments. So our telepsychiatry team really took that on as a challenge, and they did a lot of work with Lean Six Sigma, and they built a system of care around those patients. So not only do they get their telepsychiatry intervention, they also get immediately linked to our centralized patient placement team, who look all over the state for a bed, try to get that patient quickly moved if they need to be admitted. And then we have a team of telemental health clinicians who help manage the patient's care while they're in the emergency room. I'm excited to say I think our last number, we're down to 17 hours. So that's well over a 50%. So think of the change in that patient's experience of care. I mean, that's a huge impact. And to know that they're getting access to treatment immediately in the emergency room, not having to wait till they get to inpatient care, that team has made an incredible difference. And I think in the primary care integration, the experience of our primary care physicians before we started the integration program was these patients were in their office, they're there, and they didn't have support to deal with it. So they struggled to know what to do with the patient, and they might give them a prescription, or they might give them a referral to a psychiatrist, which when you go to call for that referral, it's a 6 or 8 or 9 month wait, if you even have the right payer to see a physician. And so we've given people access to treatment immediately. If they're in crisis in that primary care practice, we can get on a screen with them immediately within that appointment. Just think about that experience of care. You're not being pushed away, you're not being told to wait, you're not being told 6 months from now. You're being taken care of, and you feel taken care of. I think the work with First Break gives people hope. I know it does give families hope, because I've talked to families who have lived this experience, and they left the hospital and they didn't know what to do. And so now we have this team of people that wraps their arms around patients and helps them make that transition to living with mental illness, serious mental illness. So those are 3 examples that come to mind. We've done a lot of work on our inpatient units to think about how we understand the trauma that people are dealing with, how we change our response to them based on empathy and that approach to care. So I know our teams at Charlotte and Davidson have led a lot of work around that. So really great.
Wonderful. Tragically, many of the folks in crisis attempt suicide. So what can be done about reducing the number of those folks who slip to that point in crisis before seeking care?
The work that I've already described does a lot of that, catching people early.
Right.
I think in the behavioral health integration and primary care, about 35% of those patients express suicidal ideation, and they're in primary care. So the earlier we can intervene, obviously makes a difference. We also have implemented screening for suicidal ideation across all of our acute care emergency rooms, and that's just been in the last 5 years. In partnership with the Joint Commission's focus on that effort, we've really worked to ask the right question everywhere we interact with a patient, and to give us the experience to intervene. We are partnered with a national movement called Zero Suicide, and our hospital and our health system and our board has endorsed that work, and really excited about the work that we're looking at nationally about how to improve the skill set of the healthcare system to intervene in suicide, and to make those early actions and early interventions that change the direction of it. So I think those things are all great examples of how we're really mindful of that and really trying to make a difference.
Yeah. Well, of course, we know that mental health issues are not limited to adults, and certainly TV dramas like 13 Reasons Why have done a lot to bring into focus the concern with issues among our teens. What is being done to offer care to the adolescents, the children's aspect of mental health issues?
Yeah, sadly, Lou, that's exactly right. It's not a respecter of age either. And on our Charlotte campus, one of the first things we did is because of the lack of inpatient beds, patients were being held a long time in the emergency room. And we noted that children were mixed with adults, and we knew that wasn't a great environment of care. So we built a child and adolescent observation unit on that campus so that they would have a separate place to be cared for while they're waiting. The next thing that we have really focused on and have long focused on is our child and adolescent partial hospitalization program. And I can think of several success stories where we were able to get children involved in partial hospitalization and they never had to be on the inpatient unit. Of course, the inpatient unit is there if they need it, but we would like to avoid that if possible. The final thing is, and this is another shout out to philanthropy, we worked with a grant from the Duke Endowment and we were able to build a model of integrating behavioral health into pediatric practices, mimicked after our adult model. And so we're now in 7 pediatric practices, offering, again, immediate access to treatment. Our practice that operates out in Concord in Cabarrus County does a lot of work with the developmental pediatricians to work on brain health and take care of children who have attention deficit disorders and autism spectrum disorders. And so that team is really, those child and adolescent psychiatrists at that practice are heavily invested in focusing on that population. So there's all these things I described, but I sit here knowing, Lou, that there is not enough services in this community for children and adolescents, specifically for children and adolescents. And it's a place that we are really going to have to focus because it's a real gap.
And Martha, what about addiction when there is a dual diagnosis? What kinds of challenges do you find there?
Well, I would say it's not just a dual diagnosis. There's also just a single diagnosis of addiction in the absence of mental illness also. And it was a bit of a gap in our healthcare system, and we've worked to close that gap. We have invested in psychiatrists who are board certified in addiction medicine. It's a little different take on the treatment and the treatment model, and that board certification gives them an extra dose of knowledge on how to deal with people with addiction. We have, again, with a partnership with the Duke Endowment, we are now building a maternal wellness and recovery model. So dealing with mothers who are addicted while they are pregnant and working on getting them off of their drugs while they're pregnant so they are successfully a family unit when that baby's born, and eliminating neonatal abstinence syndrome. So that's just underway, the early stages of that. We have worked to build up our outpatient services for addiction and really strengthen the models of intensive outpatient care. We're on the verge of opening another treatment program here right in Center City, Charlotte, which is sorely needed. And we partner closely with our community health services in addiction because we do have some really good community health services, and we try to partner with them to get our patients where we need to go. We actually worked on a protocol with our call center where if a patient calls in, they can do a screen and direct them to a center where their payer will, approve it and it has the right level of care for them if it's not a service within our system. So it's, again, another opportunity to grow services. There's a gap, and I think most everyone shares that perception.
I think there's an untold story about the level at which Atrium gives back and serves this region. Talk a little bit about that.
The concept that I think Atrium Health has chosen to embrace is really the concept of value. And how do we not only take care of people's illnesses, whether they're mental illnesses or physical illnesses, but how do we do that in a way that drives the best outcomes, drives the patient's experience of care, and ultimately decreases the overall cost of care. But that requires an upfront investment in community services. And you've probably heard recently, Lou, in the news about our partnership with Novant around One Charlotte and the investment in those underserved communities. and those communities that are really starved for services, if you will. And mental health is a key element of that programmatic plan for those communities. And so we're trying to, again, bring services. By the nature of our work, we're partnered heavily with Medicaid as, you know, a payer in our state and in our country. That's the largest payer for mental health services. So we work in partnership with our managed care organization and with community mental health services to drive services. We partnered with recently a community mental health center named Monarch, who opened a child and adolescent crisis center, and we supported that with them, wrote a letter of support to actually get that built in the community. So I think building the hospital at Davidson was a tremendous investment for Atrium Health, and building this leadership team and really our work in primary care integration, all of that is an investment in the health of this community. And I'll said it all the time when I was in the children's hospital, but I'll say it again, this is where the power of philanthropy makes a difference. Just for example, in our Behavioral Health Charlotte campus, it was an office building that was converted to a hospital. So you can imagine that the design is challenging, but most challenging is access for patients to go outside, to, you know, exercise while they're hospitalized. And so we currently, in partnership with our Friends of Behavioral Health Committee, have held some fundraisers, and they are supporting our zero suicide work, as well as our, enabled us to build a big courtyard outside of our ED where patients who are being held can actually get outside in a safe place. And we're working now on building funding for a gymnasium to be added to that campus so that patients can get off of those crowded units and get into a gym and you know, work off some of that energy. So investments, they're expensive investments, and philanthropy is a great partner in making that possible.
What are the other ways that we in the community can support these programs?
I'm glad you asked that, because you made me think of something I meant to bring up. Another tremendous investment that Atrium Health has made is in a program called Mental Health First Aid. And mental health first aid is like CPR. So you remember when President Eisenhower had his heart attack, and then all of a sudden the American Heart Association and the American Red Cross said, we got to improve the ability of the community, the lay person, to respond to someone who's having a heart attack. Because remember, we walk away from things we don't understand. And so mental health first aid was developed by the National Council on Behavioral Health, along with the state of Missouri and the state of Maryland, and they developed a program, a training program, to teach a lay person how to recognize signs and symptoms of mental illness, what to say, what to do, and how to get people to treatment. So we have trained well over 7,000 members of the community in mental health first aid. In fact, I think that statistic's probably a little bit old, but we provide the instructor and the materials, and you provide a classroom and a room full of people, and we will teach the class. And it has had an incredibly powerful impact in our community and people's ability to recognize that someone needs help and feel confident to help them. And I'll give you, there's a great story that illustrates this, so I'll just share that story with you. One of our nurse leaders actually took the course. Even though she's a healthcare professional, she thought, well, I'll just take the course too. And she said shortly after that, she was in a Walmart, and she noticed that the cashier had been cutting her skin, and she could see that. And the cashier was also crying. And so she said, she had this question in her mind, like, am I ready to do this? And so she stopped when it got her turn. And she said, now picture this, I have my children, I have a basket full of stuff, and there's a line behind me. And she said, but I said to the cashier, are you okay? And she said, no, I'm not. So they signaled for the manager, they got the cashier, they got another room, got her on the line with the call center, got her connected to services. All because she had the courage not to walk away from that. So my challenge to all of us would be, you know, how do you become confident so that you could step in, take a mental health first aid class, offer a mental health first aid class, be confident in your ability to help get someone to treatment. You don't have to know how to care for them. You don't have to know how to treat them. You just have to have the confidence to step in. And many times that's all people need is an invitation or the visibility that someone cares. Someone cares about me because they feel alone in their illness. The other thing when I'm talking to community groups, I always challenge people to do is to hire someone who's in recovery. Most people in recovery, unfortunately, have some sort of criminal background. They've been arrested for something, and they don't pass the first line of our human resources checks. So one of the things that we've been very successful in changing is the ability for those people to be hired within our own system. We have a strong system of what we call peer support specialists, and they work directly with our patients. These are people with lived experience of mental illness or addiction or both. And who better to talk to a patient about that illness and the hope for recovery than someone who's living in recovery? And so those peer support specialists work on our inpatient units, they work in our emergency department, they work in our community services. One of the very first peer support specialists we ever hired, and we didn't even actually know we were doing it, it was before the term had been coined, but he was hired to be a sitter in the ED at Union, Atrium Health Union. And he was bilingual, which was even more attractive. So he would sit with patients who were being held until they could get inpatient treatment and, keep them safe. He eventually went on, when we built the community health center at Anson County, to be their van driver. So now he goes out and he picks patients up and brings them to the hospital for, make sure they keep their appointment in primary care, make sure they get their medications. And he was nominated to be a Pinnacle Award finalist, which is our highest employee award in this company, several years later. And that is the picture of success. When you can't treat people for mental illness or addiction and then push them out on the street and expect them to be successful. People need three things to be successful. They need someone to love them, they need a job, and they need a place to live. They need meaningful work, and they need a place to live. So if we can offer them health, and then we can offer them the hope of meaningful work, we're putting them on a great path to healing, and that's what we're about.
Yes. I have a business question.
Okay.
Well, traditionally, behavioral health does not create revenue for healthcare providers. So with this emphasis that is being put on innovating around behavioral health, what's the mindset that Atrium has for ROI?
Well, the mindset really goes back to something I talked about earlier, which is around the movement in our country toward value-based care. So that's care that's measured, not just did you get the service, but what was the patient's experience of care? Did they get timely access to treatment? Did they have the outcomes that were anticipated? So no longer are we going to be measured by just doing something, or be measured by what the outcome is for the patient. And many of our payer contracts are now across the country being structured to reward outcomes. And so Atrium Health's mindset is we can't take care of a person's physical health without taking care of their mental health. Driving here today, I heard a quote by C.S. Lewis, and he said, "Our body and our soul are so connected, they share the diseases of each other." And that's like the brain and the body. You're one person. That's whole person care. You're one person. You can't hope to have success in treating someone's physical illness without treating their mental illness at the same time. Getting their whole body in the right place. And so that's really the concept behind, I think, the board's investment. They saw the wisdom of taking care of a whole person. If we're going to take care of a community, we have to take care of the people in that community as a whole person.
Yeah. The future. What for Atrium and behavioral health is next?
Well, we're continuing to grow, and as Atrium grows with partners, we've recently merged with Navicent Health System out of Georgia. We're thinking about how we can expand our services to help in areas that those health systems need assistance, take some of the lessons learned. We have worked on the maternal wellness and recovery program is early and new, so we still see that as the future because we're just building it and just growing that service. And I'll expand that a little bit to include a program focused on peripartum depression, depression in pregnant women and postpartum women, and making sure that they have access to skilled treatment and people that have been trained in dealing with women who are pregnant while they're struggling with mental illness. We are really continuing to focus on expanding our brain stimulation services. That's electroconvulsive therapy and transmagnetic cranial stimulation. And those are two interventions that unfortunately stigma keeps people away from because they've been depicted in a way in movies and television that are horrifying. And we want people to know that they're incredibly effective treatments, incredibly effective, particularly for people that are medication resistant. And so how can we continue to grow and get the word out? Our corporate communications team did a great video last year to normalize the experience of a patient going through ECT and how it really changes their life. These are people who are able then to leave their home, go back to work, and be with their families, and that's just incredible. That it's unfortunate that the media has made that scary for people. And then finally, we are continue to build on our academic mission. One of the things that I didn't mention up to this point was, again, because of philanthropy, we were able to start a psychiatry residency. So to train the psychiatrist of the future. And you talk about giving back. I mean, that is a give back, because not only did we see a problem with, not being able to recruit, but the shortage of psychiatrists in this country. So if we can begin to train our own, then we can give back to this community skilled providers to contribute to the success of our patients achieving recovery. So we're now in our second year of the residency program, and we're looking excitedly to expand the residency program and perhaps even add a fellowship for training child and adolescent psychiatrists. So that's just a few things that come to the top of my head.
Just brimming with excitement. Well, we are arriving at a time I think it would be wonderful to hear from our audience. Who has a question for Martha, hear from the live audience that might get us underway?
Yeah, we're happy to take questions from our live audience as well as from our virtual audience as well. You can clearly understand why we featured behavioral health as sort of our kickoff subject to discuss at our community town hall. It's a tremendous amount of work that's being done at Atrium Health through not only here on our main campus, but throughout our health system. Incredible work. So why don't I start out with a question, since we're throwing it out. How does the impact of social media has had on our adolescent community, both positive and negative? Are you seeing the impact that that's having on our adolescent community? And I'll sit down and let folks in the audience and others ask questions.
I am not a treating clinician, so I'm going to approach this from what I hear from my team, but there's a definite impact because there's no escape from it. We talk about when we were growing up, if you were bullied at school and you came home, home was still safe. And they're not safe ever from it. And so I can also judge that by the number of requests we get from the media to have our child and adolescent psychiatrist interviewed about the impact of social media, and how we deal with that with children, particularly around, honestly, and this isn't social media, but it got a lot of play on social media, but Lou referenced the 13 Reasons Why series, and there was a huge impact in the community around that. So I know it's there. I can't give you the clinical answer behind it, but I know from what our clinicians are dealing with and what our clinicians in our pediatric practices are dealing with, it's a real problem. I will also say that we also have been successful in using social media in a positive way, however, because our corporate communications and marketing team has been very successful in helping us use social media to share the story of addiction treatment, to share the story of our brain stimulation services, positive patient stories. We actually had a Facebook Live event in response to some of the very high-profile suicides that were recently, Kate Spade and Anthony Bourdain. And during the event, a patient actually came on Facebook and stated that they were having suicidal ideations. And our team diligently, through our call center and through I don't even know how they did it, but they found her. Wow. And they got her to care. And that is powerful use of social media. So there's a balance.
Yes. We have a question coming in, which is this: I have a child with a behavioral health concern. What are the first steps I should take in getting proper care for him, and what are the options?
Well, not knowing the child and not knowing the degree of illness, I think if you're concerned for the child's well-being or concerned that they may hurt themselves or hurt someone else, then our psychiatric emergency room on the Behavioral Health Charlotte campus is very skilled at dealing with children. We have a mix of child and adolescent psychiatrists there as well as adult psychiatrists, and they will ensure that child is safe and receives immediate access to care. You can also call our call center number, and we can get you that number to put on the screen before the video is over. Our call center is extremely skilled at connecting patients and families to services who are in crisis. Your pediatrician is a great starting point because many pediatricians, again, have services in their office or know how to connect you to services. And I would say any of those would be a way to access care immediately.
Great, thank you. We have another question that's come in. What is the cost of a telepsych visit in a PCP office compared to the traditional visit of a psychiatrist?
Well, the visit in the PCP office, currently there's no additional charge to the patient. The payers don't recognize that service done on a virtual care platform, and so we believe so much in the change of outcomes that investment currently we don't charge the patient. The cost of seeing a psychiatrist, I don't know off the top of my head what that charge would be, but obviously there would be a bill for seeing a psychiatrist first place. And the interesting thing about the success of integration into primary care that this question allows me to expound on is that oftentimes patients really don't need to see a psychiatrist. And with the shortage of psychiatrists in our country, if we can help our primary care providers manage mild to moderate mental illness, then we can reserve that psychiatry manpower for the patients who are the most severely ill. And then perhaps we can hopefully be successful in our communities in getting people access. And so often we can manage that illness without you ever having to see a psychiatrist, which is great. Now there's a psychiatrist on the team that's supporting that primary care provider behind the scenes, but you don't actually see the psychiatrist in the primary care practice.
Got it. Got it. Well, we have another question here. Are telepsych visits covered by Medicaid, Medicare?
Telepsychiatry is covered by most payers when it's delivered in an emergency room, as an intervention in an emergency room. Medicare limits their coverage to rural markets, so they will not pay for telepsychiatry visits in an urban market. Our system has made the decision to offer those services anyway to a Medicare patient because we believe that it supports our emergency room providers and it supports the patient in a way that's appropriate. And we clearly cannot put a psychiatrist in every emergency room. Again, there's not enough manpower. So it's different by payer, but it's improving every day, the acknowledgement of payers around telemedicine.
Anyone here with us live have a question? Who will? Please.
I wanted to see if you could talk a little, if you could speak a little bit more about what Atrium is doing about being trauma informed.
We've had a series of really educational events for our teams around what is trauma-informed care and what does that look like. Really about how to humanize mental illness and how to see things from the person's perspective. And so we are really trying to focus on making sure that our teammates are skilled in that thought process and in that approach to patients. So we did, for a couple of years, we did a series of on-site trainings for our patients. We've also participated with the community and the managed care organization to bring speakers to Charlotte to speak and teach on trauma-informed care. And I know that on the Behavioral Health Charlotte campus, they're really focused on taking that one step further and being trained in resiliency and how to help patients build a resiliency around their illness and an ability to respond to their illness in a way that helps them manage it for themselves. And you really have to teach teammates how to work on a resiliency model. So that's the work that we've done. It doesn't sound profound, but it's pretty powerful teammate by teammate.
Here we are.
How many of the Atrium teammates have actually gone through the How many of the Atrium teammates have actually gone through the mental health first aid class?
Wow, that's a good question, Vicki, and I don't have that. I don't know from the total number how many were Atrium teammates. I know it's a large percentage. I can get you that information, but our team, many of our teammates have trained their entire, department in mental health first aid. We've also trained, interestingly, college faculty, resident assistants in dorms. Really trying to get to where people have close, intimate relationships and spend a lot of time with schools, teachers in schools. But a lot of our own teammates have been trained as well. Yeah, I'm sorry I don't have that breakdown. It does remind me that one of the community initiatives that we've done in partnership with the community around child and adolescent care is our school-based services. I didn't speak about that, but we actually partner with Charlotte-Mecklenburg schools to place licensed mental health professionals in the schools that work in partnership with that leadership team at that school to care for the children in that school and their mental health. We do that as well as several of our community mental health programs, but that gives children immediate access right in that school. So. you need to bring that up.
Great.
I applaud the efforts that are being made here, and I think your community town hall is a great innovation. And I would like to hope that this sort of thing can continue. I guess my one overall question of a list of about 1,000 would be, how do we propagate this? How do we make this become more visible to where we start to stimulate, hopefully, community interest in networking all the various unaligned efforts that are made in this field, because it's so fractured, it's so fragmented. As you say, it's labored under the stigma that's associated with something not right. But think about the brain is probably the most complex of all the organs, with all due respect to any specialist, but it really is. I mean, the holistic approach, what is the strategic vision, where is all this discussed, and who are the champions? I promised to make one question, and I ultimately violated it. So where do we go from here, I guess is the real way of saying it.
Well, I see, number one, you're our champions. The board of Atrium Health is definitely our champions and has been for a long time in making all of this happen. Our entire team is committed to spreading the word, and we have spoken all over the country, anywhere in the city that will have us. We've been in churches, we've been in, we actually teach mental health first aid to the No Grease barber training school. So those barbers are trained in mental health first aid because they have very intimate relationships with their customers. So we focus all the time on how can we get the word out and how can we talk about this more within our own community. And thankfully, the foundation came up with this idea. But one of the things you may be interested to know that we've also done is in our speaking around the country, we've gotten a bit of a national following for the work that we're doing. And so we actually built up a team last year who do this job in addition to their other job, of a consulting service. And we're actually providing consultative services to other healthcare systems. And we actually recently just helped Banner Health System in Arizona implement virtual behavioral health integration into primary care. We're also working with Indiana University Health. So we're thinking bigger than just the Atrium Health system. We're thinking about how do we change the country. My team knows I'm a little competitive, so we're like, hey, let's go get it, and let's improve the care for patients anywhere in this country that are accessing our healthcare system. And so we're really trying to think big about that and how we get the word out. I think the Friends of Philanthropy group that was formed at the foundation, that committee, and the work that they've done with the luncheons has been incredibly impactful. We've had large attendance at those luncheons. We've had great speakers. We, I think, have challenged people to think differently about mental health. When I left the Children's Hospital, I well understood the power of philanthropy. And I realized we didn't have any in behavioral health. And I challenged the foundation, like, let's think about behavioral health in this work. And they have taken it on. And I think we are really getting an audience that we would never have had before through that event. I want to take the opportunity, while I have the floor, to just acknowledge Bill Blue, who's in the audience. Bill was one of our early friends in this work. And Bill and his wife, Betsy, put together a team and went down the course of philanthropy and actually built a service in our community that really did not exist. And that is Hopeway, and that is step-down care. And that's that gap between when you leave the hospital and when you're really in recovery. And so they've really stepped up to build services up in this community, and we're grateful to you for that.
Wonderful. We have one more question. What programs do you have in place for first responders and ED staff to handle compassionate fatigue from the opioid epidemic?
That's a great question. I don't know that I can give a specific answer, but just some of the things. I think our healthcare system is conscious of compassion fatigue, and they've started some specific interventions around a program called Code Lavender, which is really about surrounding people when they most need that emotional support and making it okay to need emotional support. We're tough healthcare providers. We're here to save your life, so we don't allow ourselves sometimes to acknowledge that we're burning out. And so the opportunity to acknowledge that as a healthcare system, put a name on it, I think is powerful. We also, the call center operates and our employee assistance program operates to support all of our employees. And they are all, know that is one of the benefits that's paid for by the healthcare system, and they have access to services anytime they need it through the call center and the employee assistance program. The other thing I think is just giving people tools to fight the fight. So working to get access to our first responders to be able to give Narcan and reverse an overdose. Helping people understand the opiate epidemic and do the things that that's a hard word to say, the things that they can do to change that. So how do you change prescribing habits so you don't continue to contribute to the problem? How do you understand prescribing? And those are all just tools. It's a toolbox full of tools that we're trying to give these teams. We do work with our first responders and our Charlotte Police Department to train them and work with them in crisis intervention and crisis intervention techniques when they have combative patients or patients that need to be physically restrained, how to do that the right way, how to de-escalate people so you can avoid having to physically restrain them. So those training programs are all in place, but it is just a big toolbox, not one program.
Is there anything that we haven't covered about this incredibly getting our arms around what is so exciting that's underway here? Anything that we've not touched on that you would want us to know about?
I'm pretty sure the minute I step down there, I'll think of it. But we've talked a lot today, and I'm so grateful for the opportunity for behavioral health to be the inaugural event and to talk about the exciting work our team has done over the last many years.
Great. Help me thank Martha Whitecotton today.
Thank you to Lou Solomon. It's been a great mediator.
Gosh, my pleasure.